For the concept of perfusion, we have two exemplars. One is the peripheral vascular disease and pulmonary embolism. My source for this lecture is the Lewis Medical Surgical Nursing 11th edition. So peripheral vascular disease involves the arteries and the veins. And we're going to start with discussing the peripheral arterial disease. So for the peripheral artery disease, it involves the narrowing of arteries in the upper or lower extremities, or it can be in both areas. So with the pathophysiology of this disease, there's a progressive chronic obstruction of blood flow through the large peripheral arteries. And because of that obstruction, this can lead to inadequate tissue perfusion of the muscles, of the organs. It can then lead to ischemia, and it can lead to necrosis. And of course, if there's no blood flow, that can lead to cell death. This peripheral artery disease is more prevalent as the person increases with age. It is symptomatic between the age of 50 to 70 and is related to a cardiovascular disease, and it's one of the risk factors for cardiovascular disease. A common cause of peripheral artery disease is atherosclerosis. So, atherosclerosis is the deposit of cholesterol, lipids, or fats in the vessel wall leading to narrowing. So, if you can see here in the illustration in this slide, there is a normal artery, and you will see that there's the lumen is clean, there is no blockage, and compare that to the artery on the right side, where you can find an artery narrowed by plaque. Those yellow circular areas represent cholesterol and lipids that has deposited in the blood vessel wall, creating an atherosclerotic plaque. So risk factors for peripheral arterial disease involves modifiable and non-modifiable risk factors. Modifiable risk factors are those factors that we can change, those factors that we can alter. Examples are smoking, hypertension, diabetes, dyslipidemia or high lipid or fat levels in the blood, sedentary lifestyle. We can certainly change or alter that, obesity, and ineffective stress management. The non-modifiable risk factors, or risk factors that we cannot change, are our age, gender, ethnicity, and family history, especially family history of coronary artery disease. Atherosclerosis, or the thickening of the vessel wall caused by deposits of lipids and cholesterol, is the most common risk factor for peripheral artery disease. This slide shows us the common sites of peripheral artery disease in the lower extremity. You will see here the popliteal artery, the deep femoral artery, common iliac artery, even the anterior tibial artery. So those are the most common sites of peripheral artery disease in the lower extremity. A classic manifestation or a classic symptom of peripheral artery disease is intermittent claudication. So claudication means there is pain during exercise and relieved by rest. The pain is due to the buildup of lactic acid during exercise. So how does this happen? So when a patient is exercising and when there is not enough oxygen to produce energy during exercise, lactic acid builds up in the muscles. So a remedy for this, you might have heard this, they always say that you hydrate yourself so you can get rid of the lactic acid, and you warm up before exercise. So a classic symptom of peripheral artery disease is intermittent claudication, pain, and if the involvement is in the iliac arteries, so peripheral artery disease involving iliac arteries, The claudication may be located in the buttocks and the thighs. Peripheral artery disease of the femoral and popliteal artery. The pain may be located at the back of the legs, or the patient may have calf pain. There is also paresthesias or numbness or tingling of the toes and the feet. And this is related to ischemia. There's peripheral neuropathy, which is shooting pain or burning pain in the extremity. And this is mostly experienced by patients who have diabetes. So in peripheral artery disease, the severity of the symptoms depend on the site, it depends on the extent of the blockage, and the amount of collateral circulation. So by collateral circulation, we mean an alternate circulation around the blocked artery or vein. So of course, if there is a great amount of collateral circulation or an alternate circulation, there will be lesser pain compared to a patient who has not developed any collateral circulation. To continue with pulmonary artery disease manifestations, you will also notice that the skin is thin, it's shiny, it's taut, or it looks like it's been stretched out. There is poor nail growth on the toes or hair growth on the legs. Pulses are decreased or absent, especially in the pedal, popliteal, and femoral artery. The foot or the toe, if there are wounds in the foot or toe, you will notice that it does not heal well or it heals slowly. There is blanching or pallor of the extremity when elevated, and we call that elevation pallor. But if there is redness or reactive hyperemia when the extremity is lowered, and we call that a dependent rubor. There is a marked decrease in the temperature of the lower leg or the foot compared to the other leg or the rest of the body. There is decreased temperature because there is not enough blood supply. There is marked decrease in temperature of the lower leg compared to the rest of the body. And as the peripheral artery disease progresses, rest pain is often felt at night. This slide, I got this from another textbook, and I just found this interesting because it staged pulmonary artery disease. So stage 1, the patient is asymptomatic. There's no claudication. There is no complaint of pain. However, the healthcare provider may notice some bruit or may notice some decreased pulses in the involved extremity. Stage 2, there is a presence of claudication. Stage 3, the patient will have pain even at rest, and the patient may be awakened at night because of the pain, and the pain is relieved by putting the extremity on a dependent position or by lowering the extremity. Stage 4, there is necrosis or gangrene. Sometimes you can find ulcers, black tissues on toes, foot, or the heel of the foot. So complications of pulmonary artery disease involves limb ischemia, or there is decreased blood flow to the extremity. There is severe pain distal to the level of the occlusion. There is 6 P's of ischemia that our book mentions. The 6 P's signifying the presence of ischemia would be pain, pallor, pulselessness, paralysis, paresthesia, or poikilothermia, or the involved area is cool to touch. Another complication is the presence of arterial ulcers, most often in bony prominences. Our book also mentions something, there is a table on page 802, 37.1. They mentioned something about ulcers, and ulcers of peripheral artery disease is mostly seen in the lateral malleolus. It is round, smooth. It looks like it's been punched out. There is minimal drainage. but the tissue is black eschar or with pale or pink granulation. And this is to differentiate it from ulcers of of the venous blood vessels, wherein the ulcers are found mostly in the medial malleolus. Another complication is gangrene or death of the body tissue due to lack of blood flow. There are different diagnostic tools to diagnose peripheral artery disease. One is the Doppler ultrasound. So you've all seen what an ultrasound is, and this is quite similar to it. They use a probe, a Doppler ultrasound, to determine the degree of blood flow in the involved area. And it is also used to obtain a segmental blood pressure. So a segmental blood pressure or segmental arterial Doppler pressure is a test that uses the Doppler ultrasound to measure the blood pressure in the legs and to make sure that there is normal blood flow. So this test is usually done when there is intermittent claudication. What they do is that they apply a sphygmomanometer or that BP cuff in different areas of the leg. They apply one on the thigh, below the knee, and at the ankle level. And they obtain a segmental blood pressure. They determine how well the blood flow is on those different areas of the leg. And for that, they will need the Doppler ultrasound. Another diagnostic method is an angiography. For an angiography, it uses a dye or a contrast material which is injected into the blood vessels. And what they will do is that once they have injected that contrast material, the patient will undergo an imaging study such as an X-ray or a magnetic resonance angiography to view how that blood flows through the arteries in the body, and they will determine or they will see where the blockage is located. The angiography shows the location and shows the extent of the peripheral artery disease. Another method for diagnosing peripheral artery disease is the ankle brachial index or the ABI. Is a peripheral artery diagnostic screening tool. It uses a Doppler probe to compare the ankle blood pressure to the brachial blood pressure. And normally, the ankle blood pressure is greater than the brachial blood pressure. So what they do is, again, they apply a BP cuff and they use the Doppler probe to obtain the blood pressure. They calculate it using a formula. So the ankle brachial index is equal to the ankle blood pressure divided by the brachial blood pressure. So a diagnostic result of 0.9 or less than 0.9 is diagnostic of peripheral artery disease. So how is peripheral artery disease managed? First of all, the goal is to reduce the risk for cardiovascular disease. What we want is for this patient to be at less risk or reduce the risk for cardiovascular disease. So the first mode of treatment is to be able to control the patient's blood pressure or to control hypertension. We control hypertension through lifestyle changes, decrease in the use of salt or sodium, low-fat diet, high-fiber diet, or that DASH diet, which is the dietary approaches to stop hypertension. We advise the patient to stop smoking, and if they are diabetic, to maintain a hemoglobin A1C level of below 7%. Higher than that, some patients with diabetes and peripheral artery disease may be at risk for amputation of that limb. Another management is exercise therapy. It's found out that patients who exercise regularly have better survival rate. What is recommended is to exercise 30 to 45 minutes per day, at least 3 times per week. Another one is to make sure that there's good nutrition or nutrition therapy, and maintain a normal weight or maintain a BMI of less than 25. Medications for peripheral artery disease includes antiplatelet medications, which reduces the risk for cardiovascular disease. An example of antiplatelets is aspirin. Patients are given either the 325 milligrams or 81 milligrams aspirin. And of course, Plavix is also an antiplatelet. Typically, the patient can be given 75 milligrams daily. The role of antiplatelet is to prevent platelets from sticking together and forming clots. Patients who are taking Plavix and at the same time omeprazole or Prilosec, there's a little issue in here because the effectiveness of Plavix is reduced with the intake of omeprazole. So either they will change the patient to another antiplatelet medication, or they will change the omeprazole to another kind of medication, either a proton pump inhibitor or another H2 blocker. ACE inhibitors are given also for patients with peripheral artery disease. ACE inhibitors, as we know, are vasodilators. So any atherosclerosis can help. ACE inhibitors can help with that. Any narrowing of the arteries, ACE inhibitors may help with that. Examples of ACE inhibitors are captopril, enalapril or Vasotec, lisinopril or Lotensin. Another medication are statins or lipid-lowering agents. We know peripheral artery disease, that patient can have atherosclerotic plaque. So lipid-lowering agents such as pravastatin, Crestor, simvastatin or Zocor, atorvastatin or Lipitor. What we want is a low density lipoprotein, lower than 100 milligrams per deciliter. And of course, a patient also given IV heparin as a peripheral artery disease medication. So to continue with medications for peripheral artery disease, Trental is given. It reduces blood viscosity or reduces the thickness of blood to improve circulation. However, this medication, it takes 2 to 4 weeks to 8 weeks for its full effect. Pletal is another vasodilator which inhibits platelet aggregation. However, it is contraindicated in patients with heart failure because it increases heart rate and it affects the heart rhythm. Another management for peripheral artery disease would be an angioplasty. So in an angioplasty, an arteriograph may be performed. With this procedure, a cannula is inserted at or above the occluded blood vessel to open up the blocked blood vessel. They use a flexible catheter with a balloon tip to dilate the blocked blood vessel, and after that they may put a stent to be used to keep that blood vessel open. The catheter can be inserted transfemorally through the brachial artery or through the axillary artery. In an angioplasty, it can also be laser assisted, which in a laser heat vaporizes the plaque to open up the blood vessel. There is such a thing as a percutaneous transluminal angioplasty or PTA, and it's a procedure that can open up a black blood vessel, and that's the same as that angioplasty that's presented here. So with that percutaneous transluminal angioplasty, that's just another name for it. And again, what they do is that there's a flexible plastic tube or catheter with a balloon at the tip, and it inflates the blood vessel or artery so that normal blood flow is restored. Another procedure is arterectomy. It is used for very hard or calcified lesions. It removes the plaque by breaking it into microfragments. What they use is a high-speed rotary metal burr. It grinds or burrs to break up the very calcified plaque. Um, it can cut the plaque into long strips, or it can break it up into microfragments. They may also use a laser arterectomy, where they use a UV light to break up those plaque or break up the calcified lesions. Cryoplasty is a management wherein they will combine an angioplasty with cold therapy. What they do is that there's a balloon that's filled with liquid nitrogen, and they will insert that either again through the femoral, brachial, or axillary artery. And then that liquid nitrogen changes into gas as it enters the vessel and as it enters the balloon. So the cold temperature limits the chances of restenosis, or limits the chance of that blood vessel to narrow again. So another management is bypass grafting, which this is a surgical procedure to increase the blood flow to the affected limb. So if you look at the illustration on the right side, you will note where the blocked artery is, and they use the bypass graft. So they perform an arterial revascularization, wherein they use a part of a vein, the saphenous vein, the cephalic or basilic vein in the arm. They use that to bypass the blocked artery. And of course, a synthetic graft may also be used, but like we said, the saphenous vein or veins in the leg, or the cephalic or basilic vein can also be used. And arterectomy is another procedure wherein they can open up the artery by removing the obstructing plaque. So this is a more really a more invasive procedure, wherein they open up the artery itself and remove the obstructing plaque. This is another illustration of a bypass graft. So you will see here where the blockage is, right there at the femoral artery, and they use a bypass graft to bypass the blocked artery and restore the blood circulation. So appropriate nursing diagnosis for peripheral artery disease, of course, very obvious: ineffective tissue perfusion, risk for impaired skin integrity because of the development of ulcers. Skin may be taut, skin may be thin. There is chronic pain, intermittent claudication, and of course, because of the leg pain, there might be activity intolerance. Health promotion or prevention of peripheral artery disease would involve teaching the patient the proper diet, specifically diet that is low in cholesterol, low in saturated fat, and low in refined sugars. Teach also the patients, especially the patients that are diabetic, the proper foot care and prevention of injury. And teach the patient regular follow-up, teach the patient medication compliance. So for acute care, this is care for a patient who had peripheral artery disease, and the patient had surgical and radiologic procedures. So this is the care for them. First, let's check the extremity every 15 minutes, then hourly. And what do we check? We check for the color of the skin, the temperature, we check for capillary refill, the pulse, let's check for the sensation and the movement of the extremity. Let's assess for the patient's pain, assess for complications of the procedure such as bleeding, hematoma, thrombosis or clot, embolization, or when the clot has traveled from its original location. Um, let's check for compartment syndrome. So compartment syndrome is a painful condition that occurs when pressure within the muscle builds up to a dangerous level. This pressure can cause decreased blood flow. So let's check for that compartment syndrome. Let's check for increasing pain, loss of pulses, the extremity, what color is it? Is it pale? Is it cyanotic? Let's ask the patient for any numbness or tingling of the extremity. We'll also have to advise the patient um, do not or avoid the knee flex position because that hinders blood flow. Um, Again, this is for a patient who just had surgery or radiologic procedure. We support any incision with pillows. We assist the patient with ambulation. We discourage prolonged sitting with legs lowered to reduce pain and edema right after a surgical procedure. We advise the patient to use compression stockings to reduce leg edema after the procedure, assess for infection, um, we provide wound care, and we start with supervised exercise program and then gradually increased walking. So this is an interesting slide which shows us how the compression stockings work. If you look at the left side, look at the leg with swelling and with blood clot, and look how that and look at the leg on the right side, wherein because of that stockings that has compressed the legs, it reduces blood pooling, there's less inflammation, and it has increased blood flow. So care for the patient with peripheral artery disease in the ambulatory setting will be to assess for their cardiovascular disease risk, like assess for history of hypertension, history of diabetes. We educate them on their medications, advise them to exercise regularly for those patients who have diabetes, check their foot, inspect the legs and the feet daily, follow up with the podiatrist for nail care, wear clean all cotton socks, wear comfortable shoes with rounded toes and soft insoles, and remind them not to put the shoes too tightly, so lace those shoes loosely and avoid crossing their legs. So far we've talked about peripheral artery disease. Now let's talk about venous insufficiency. So in here, the problem is not anymore in the arteries, but now it's in the veins. In venous insufficiency, the problem is the dysfunctional venous valves. Normally, those venous valves are unidirectional. It allows blood to return back to the heart in one direction, but because the valves are dysfunctional and the valves do not close properly, it allows blood to back flow into the venous system. Because of that, blood pools in the legs, and this is all because of those dysfunctional venous valves. The patient will have symptoms, and the patient may say that their legs feel heavy, it looks like there's edema, dermatitis, it's itching, there is wet wounds from ankle to calf area, there is a rusty discoloration of the lower legs, and we call that hemosiderin staining. Capillary refill, however, is less than 3 seconds, which is normal. Skin is warm, thick, hardened, and indurated. There may be ulcers in the medial malleolus, and to compare this with peripheral arterial disease, the ulcers most commonly are seen in the lateral malleolus. The patient will report that when they elevate the legs, they find comfort in that. So The elevating the legs will provide relief from pain and discomfort. So to compare peripheral arterial versus venous insufficiency, one of the criteria that our book mentions is the ankle brachial index, the capillary refill, edema, which is absent in peripheral arterial disease. Hair is absent in peripheral arterial disease. Nails are thickened in peripheral arterial disease. Both will have symptoms of pain. In peripheral arterial disease, the arterial pulses can be absent or decreased. However, it's present in venous insufficiency. Skin color in peripheral arterial disease will be reddish, or there is dependent rubor. And in venous insufficiency, the skin color can be bronze brown. The skin temperature in peripheral arterial disease is cool, and it's warm in venous insufficiency. Like we mentioned about ulcers, ulcers are in the most likely in the medial malleolus in venous insufficiency and lateral malleolus in peripheral arterial disease. Another problem with peripheral vascular disease is venous thrombosis or blood clots in the veins. Venous thrombosis is the formation of thrombus or clot with vein inflammation. The preferred terminology for it is venous thromboembolism, which includes the spectrum from deep vein thrombosis to pulmonary embolism. So the word or the terminology venous thromboembolism includes the blood clot in the deep veins, which is deep vein thrombosis, to pulmonary embolism, where that blood clot dislodges and travels to the lungs. So venous thrombosis could be either superficial or deep. The superficial vein thrombosis usually involves the saphenous vein or the vein at the back of the leg. Deep vein thrombosis involves the iliac or the femoral vein. And the illustration here on this slide shows us where the location is. So look at where the femoral vein is, and that is under the category of deep vein thrombosis. And look where the saphenous vein is, and that's the superficial vein. Venous insufficiency is characterized by the virtuous triad. So the virtuous triad includes three factors. The first one is venous stasis. So venous stasis means blood pools or collects. Because the valves in venous insufficiency are dysfunctional, so we described how blood pools or collects on the lower legs. So that is venous stasis, blood pools or collects. This occurs mostly in obese patients, pregnant, those with chronic heart failure, with atrial fibrillation. Those also occurs in patients who are immobile, for example, an airplane travel or a long trip without exercise, without getting up to walk, a prolonged surgical procedure, immobile for long periods of time, such as after a spinal cord injury or a fractured hip or limb paralysis. So those kinds of conditions would render the patient immobile or with very limited movement for a long period of time. The second part of the virtuous triad is endothelial damage. Endothelium is the lining of the veins. So there is damage in the lining of the veins, and can be caused by surgery, by intravascular catheterization, trauma, burns, or a prior venous thromboembolism. The third part is hypercoagulability of the blood, or there is an increased tendency of the blood to clot. And this occurs in conditions such as anemia, polycythemia, cancers, nephrotic syndrome, sepsis, intake of estrogen or corticosteroids. Risk factors for venous thromboembolism includes the use of alcohol and tobacco, women in childbearing age and using contraceptives, postmenopausal women on hormone therapy such as estrogen, those over the age of 35, and of course the family history of venous thromboembolism. So as mentioned earlier, blood clots in the veins includes those involving the superficial veins and the deep veins. Manifestations of superficial vein thrombosis includes a cord-like vein that's palpable and firm. The area involved is itchy, tender, red, warm. Patient may have fever, leukocytosis, or increased white blood cell count. There's edema in the involved area, and usually it involves the varicose veins. The risk factors include increasing age, pregnancy, obesity, recent fracture, use of estrogen, recent treatment for varicose veins, recent surgery, long distance travel, hypercoagulability, and history of venous thromboembolism. Um, to manage superficial vein thrombosis, first they have to determine the location and to confirm the clot. So ultrasound may be performed. NSAIDs can be given to relieve pain and to provide warm compress to the patient to provide comfort. Um, Patient can also be advised to use a graduated compression stockings. The legs are advised to be elevated above the heart, and mild exercise such as walking is recommended. So I've talked about superficial vein thrombosis in the previous slides. Now this slide is talking about venous thromboembolism, which includes deep vein thrombosis. So manifestations of that, patient may have or may not have any edema. The patient will definitely complain of pain, tenderness. There could be dilated superficial veins. The patient may complain of fullness or heaviness on the thigh or the calf area. There can be tingling and on the toes and lower extremities. Skin is warm, erythema. Systemic temperature could be greater than 100.4. If the inferior vena cava is involved, there could be bilateral edema and cyanosis extending into the internal jugular vein or the superior vena cava. How to diagnose this? Ultrasound, and there's going to be a blood work or a D-dimer that's going to be ordered for this patient. Complications of venous thromboembolism includes pulmonary embolism, wherein the blood clot in those deep veins get dislodged and travels into the lungs, blocking airways. Another complication is chronic thromboembolic pulmonary hypertension. So pulmonary hypertension is due to the damage on those venous walls and the vein valves. So what happens is that the damage causes an increase in pressure on the pulmonary circulation. Post-thrombotic syndrome is due to the chronic inflammation and chronic hypertension. I'd like to go back to the D-dimer. The D-dimer is a protein fragment that's made when the blood clot dissolves in the body. A high dimer indicates that there may be a significant blood clot or a thrombus formation and breakdown in the body, but it does not tell where the location or the cause of the blood clot. Now, ultrasound will definitely tell us where the location of the blood clot is. Again, to go back to the complications of venous thromboembolism, there can be swollen, blue, or painful leg. If there is near occlusion of that vein, again, pain, cyanosis of the extremity. If untreated, could cause gangrene and amputation. So to continue with diagnostic studies, again, ultrasound may be ordered, a computerized tomography, venography, wherein there could be a contrast material injected, and there could be an imaging study wherein they will find out how the dye flows through the venous system to find out where the blood clots are. Again, a D-dimer is ordered. So a positive D-dimer result may indicate presence of an abnormally high level of fibrin degradation products. It indicates that there may be a significant blood clot or thrombus formation and breakdown in the body. A negative D-dimer will rule out DVT or venous thromboembolism. A positive D-dimer suggests DVT, and it needs to be investigated. Fibrin studies can be ordered. Activated prothrombin, activated partial thromboplastin clotting time can be ordered, because that is the test that measures how long it takes for blood to form a clot. The INR, or international normalized ratio, can be ordered, and that is the measure of how long it takes the blood to form a clot. So if the patient is taking a blood thinner, example like warfarin, the therapeutic range here will be 2 to 3 seconds. Bleeding time is ordered, hemoglobin and hematocrit, and also platelet count. So the goal for treatment for venous thromboembolism is to prevent a clot formation. And we can do that through early mobilization, changing of position every 2 hours for those patients who are on bed rest. Patient can flex, extend the hips and feet every 2 to 4 hours unless contraindicated while they are awake. Walk at least 4 to 6 times per day. Sit for meals at the side of the bed, and a TED hose can be given to this patient. So a TED hose is a thromboembolic deterrent, but it should not be used if there is already an existing thrombus. So TED hose is given to the patient for prevention of blood clots, but if there's already a blood clot, it is not used for those patients. A pneumatic compression device such as an STD is also given to the patient for prevention, but not if there's already an existing blood clot. So drug therapy for venous thromboembolism, the goal for treatment or for the use of this drug therapy is to prevent new clot formation, to prevent the spread of the clot, and to prevent embolization or the embolism into the pulmonary circulation. One drug that can be used is warfarin or coumadin. It's classified as an anticoagulant. It can take up to 48 to 72 hours to take effect. So for the meantime, the patient may be given a low molecular weight heparin or Lovenox. They can be given Lovenox subcutaneous with warfarin. Warfarin is given as a oral medication, and patients on warfarin needs INR monitoring. The antidote for warfarin-related bleeding is vitamin K primarily, but the patient can also be given fresh frozen plasma, prothrombin complex concentrates such as K-Centra. Patients on coumadin or warfarin should not be given any NSAIDs, and they should limit the use. They should limit a diet with green leafy vegetables, because green leafy vegetables has vitamin K, and it may interfere with the therapeutic level of warfarin. So to continue with drug therapy for venous thromboembolism is heparin. So heparin is classified as an unfractionated heparin. it acts as a thrombin inhibitor, so it inhibits blood clots. It is given as a subcutaneous injection for venous thromboembolism prevention, and it's given IV for venous thromboembolism treatment. Now, heparin needs an APTT monitoring. For patients who are taking heparin, we want the therapeutic value to be within 40 to 70 seconds. Protamine sulfate reverses the effect of heparin, so protamine sulfate is the antidote for heparin. One serious side effect of heparin is the heparin-induced thrombocytopenia. So heparin-induced thrombocytopenia is an immune reaction to heparin causing severe reduction in platelets. It is diagnosed by measuring heparin antibodies. So the treatment for this is to stop the heparin and give non-heparin anticoagulants such as Arixtra or ARIXTRA, so Arixtra. Another side effect of heparin is osteoporosis. Another drug is Lovenox. So we know that Lovenox is given sub-Q. It's given at the love handle on the abdomen, on the side of the abdomen. So that's easy to remember. Lovenox given on the love handle on the lateral side of the abdomen. So Lovenox is a low molecular weight heparin given subcutaneous. So when you get Lovenox, how it's prepared is that it comes in a glass syringe, is a pre-filled syringe, and you can see air on top of the medication. So that air should not be expelled. That air you should inject that with the air on that syringe. And like I said, it's given subcutaneous. So when it's given subcutaneous, we do not aspirate, you do not massage the area, and you give it subcutaneously. Other medications are Pradaxa, given orally. Again, also it's a thrombin inhibitor, is given as a venous thromboembolism prevention. Xarelto is also a very common medication given PO for prevention and treatment. Eliquis is given PO for prevention and treatment. So far we've been talking about anticoagulants to prevent blood. It's an anti-clotting. But there are also medications classified as thrombolytic agents. So these agents not only are anticoagulants or anti-clotting, but they dissolve the existing clot. And these are medications, the example for these medications are urokinase and the TPA. You see this most commonly in patients with myocardial infarction, and this has to be given within a certain number of minutes from the diagnosis of myocardial infarction. So these thrombolytic agents dissolve the clot itself. Those are urokinase, streptokinase, and TPA. It's given for acute, symptomatic, and extensive venous thromboembolism. So before I end with this part on thrombus formation or venous thromboembolism and peripheral vascular disease, I'd like to touch on some herbal supplements that may affect clotting. So some herbal and dietary supplements may increase the risk for bleeding. So we should advise our patients to consult the healthcare provider before taking any herbal supplements such as garlic, ginkgo biloba, ginger, ginseng, green tea, even melatonin, niacin, omega-3 fatty acids, psyllium, and turmeric. So if the patients are on anticoagulants, we should advise them to let the physician know or the healthcare provider if they're taking any herbal supplements or if they plan to take any herbal supplements. Another kind of management for thrombus formation is venous thrombectomy. In this kind of procedure, they perform an incision through the vein itself to to physically remove that clot, and then anticoagulants are given later on. Also, the patient will undergo a green filter um, insertion or a Venatech or a trap is filter. So more commonly here is the green field filter. So what happens here is that they will insert a catheter and then through the femoral vein until the inferior vena cava, and they will insert a greenfield filter. So this greenfield filter acts as a sieve or strain. It filters the clot and it is used to help capture the clot. So once throughout the circulation, this filter captures the clots, and of course the patient will also be given anticoagulants. So nursing diagnosis appropriate for venous thromboembolism will be acute pain. Of course, there's risk of bleeding, impaired tissue integrity, and impaired physical mobility due to the patient's limitations from pain, from edema, from heaviness on the legs, um, and risk for bleeding because patients can be on anticoagulants or thrombolytic therapy. So nursing interventions in patients during the acute stage of their illness or patients admitted in healthcare facility. So it's important that we review medications with these patients. It's important that we let them know what are the medications for and how it acts in the body. We have to let the patient know, of course, that if they're on warfarin or heparin, they will have to have their blood tested to monitor for the INR and APTT. And we know that if the patient is on heparin, they can be at risk for thrombocytopenia. So CBC is ordered for the patient. Platelet count is monitored, and also creatinine. Monitor for risk of bleeding for the patients. Let's monitor the color of their stools. We have to monitor for any gum bleeding. We have to monitor for any excessive bleeding during IV insertions. We should know the reversal agents of the medications we give. So if it's warfarin or Coumadin, it's vitamin K, and if it's heparin, it's protamine sulfate. We encourage early ambulation for our patients. We avoid IM injections due to the risk of bleeding. We observe for signs of bleeding: hypotension, tachycardia, hematuria, blood in the urine, melena, hematemesis, petechiae, bruising, bleeding from the incision, or trauma. And as I mentioned earlier, we have to monitor the stools. We have to monitor the injection sites that we have performed. We have to teach the patient to report bleeding such as black stools, bleeding gums, bloody urine or sputum, coffee ground vomit, excessive menses, and nosebleed. Let's assess the patient for mental status changes because there could be signs of cerebral bleeding. We have to remind the patient to avoid aspirin, NSAIDs, and those herbal medications, as we mentioned earlier, fish oil supplements, garlic, ginkgo biloba, and Bactrim. So patients in the ambulatory care setting or outpatient setting, these are the interventions. These are some discharge teachings on modifying the patient's risk factors. First and foremost, stop smoking. We should tell our patients also to avoid restrictive clothing because it can cause constriction of those vessels and hinder the smooth flow of blood or circulation. If with venous thromboembolism, patients should stop oral contraceptives or hormone therapy. They should limit standing or sitting motionless. They should limit leg-dependent positions. When traveling, let's advise our patients to exercise the calf muscles, take short walks, drink non-alcoholic drinks, so hydrate themselves, and non-caffeinated drinks. They can use a compression stockings during travel to reduce edema. Teach the patient signs and symptoms of pulmonary embolism, such as sudden dyspnea, tachypnea, and pleuritic chest pain. We also need to review medications with our patients, side effects, and how to administer the medications. Avoid contact sports due to the risk for bleeding. Fall risk precautions for our patients. Apply pressure on bleeding for 10 to 15 minutes, because especially on those patients on anticoagulants. Suggest to the patients a well-balanced diet. Avoid foods with vitamin K because it may interact with the therapeutic levels in patients taking warfarin. Avoid alcohol, proper hydration. On obese patients, limit carbohydrates and increase physical activity. And of course, the use of compression stockings to limit edema and to promote circulation. So be sure you take a look at these tables. I summarized the patient teaching and discharge instructions, and so be sure you take a look at these pages and the table here that's presented to you on this slide. So let's proceed with pulmonary embolism. So, pulmonary embolism is a condition wherein there is obstruction of one or more branches of the pulmonary artery. The obstruction, caused by a blood clot or a thrombus formation, has its origin from other parts of the body. Most commonly, the origin will be at the lower extremity. The blood clot in the lower extremity travels from the lower extremity to the pulmonary circulation, obstructing pulmonary circulation. What happens is that the clot that has traveled, it's now called an emboli. It does not stop moving until it lodges into a narrow part of the circulatory system. The obstruction, commonly a thrombus, but it can be a tumor, it can be a fat emboli, or it can be an air emboli. Most of these thrombus or clot arise from deep vein thrombosis or of the deep veins of the legs. Most common sites are the femoral or iliac veins, the right side of the heart caused by atrial fibrillation, pelvic veins after surgery or childbirth, and the upper extremity after IV catheterization. If it's a fat emboli, most commonly it comes from a fractured long bone. If it's an air emboli, it most probably comes from an improperly administered intravenous therapy. There is also an amniotic fluid, tumors, or bacterial vegetations that come from heart valves. So, risk factors for pulmonary embolism includes immobility or reduced mobility, surgery within the last 3 months of the pelvic area or lower extremity, a history of DVT, cancer, obesity, the use of oral contraceptives, hormone therapy, or use of estrogen, because we know estrogen increases the plasma concentration of clotting factors. Cigarette smoking, we know that smoking affects blood clotting and circulation. A prolonged air travel because of poor circulation. Pregnancy, puts the veins in additional pressure. The enlarged uterus causing pregnancy increases the risk because it puts the veins of the lower body under additional pressure. And clotting disorders. Clinical manifestations of pulmonary embolism includes a sudden intense dyspnea. There is pleuritic chest pain, tachypnea, tachycardia due to hypoxemia, and hypotension. There is cough, hemoptysis or blood in the sputum, right-sided failure due to the involvement of pulmonary circulation, crackles on auscultation, jugular venous distension. The patient has a hard time breathing, the patient has chest pain, so there could be anxiety, restlessness, confusion, and because of hypoxemia, the patient will have change in mental status. If left untreated and undiagnosed, 10% of those with pulmonary embolism die within the first hour. The complication involves pulmonary infarction or death of the lung tissue. So remember, in pulmonary embolism, there is occlusion of pulmonary circulation. So there's not enough blood going into the lungs. There's occlusion of pulmonary vessels. It is due to insufficient collateral blood flow, due to pre-existing lung conditions. So there could be pulmonary infarction or death of the lung tissue. And there could also be pulmonary hypertension due to hypoxemia. So diagnostic studies for pulmonary embolism involves first venous ultrasound. Venous ultrasound helps to detect blood clots in the veins of the legs before they become dislodged and pass to the lungs. It can also show the movement of blood within the blood vessels. The D-dimer is another test, and we've mentioned that before. It measures the amount of fibrin fragments. So usually in healthy people, these fibrin fragments are rarely found in healthy people. So a negative D-dimer means that there's no clot. A positive D-dimer, it means that there are the presence of fibrin fragments. So there's a positive D-dimer. So it means they need to investigate because there's a possibility of blood clot. See, the thing is, D-dimer is not specific. It means that other conditions can cause the elevation of D-dimer. It's not sensitive to just a specific pulmonary embolism. Other conditions can cause the elevation of D-dimer. That's why a negative D-dimer means no blood clot. A positive D-dimer means there is presence of clot, but it still needs to investigate to definitely confirm that there's a diagnosis of blood clot, because there are other conditions that can cause elevation of D-dimer. Another diagnostic test is the spiral or helical CT scan or CT angiography. With this diagnostic test, there is a contrast media that's injected into the patient to view the pulmonary vessels. It is a common test to diagnose pulmonary embolism. It's spiral or helical CT scan because it takes a 3D picture of the lungs. Another test is the ventilation perfusion scan or the VQ scan. This is a nuclear medicine scan that uses radioactive material to examine the airflow or ventilation, and also to examine the blood flow or the perfusion in the lungs. The aim of this scan is to look for evidence of any blood clot in the lungs that could cause pulmonary embolism. So a VQ scan is carried out in two parts. The first part, the patient will breathe in a radioactive gas, and pictures or images are taken to look for the airflow in the lungs. In the second part, a different radioactive materials is injected into the vein in the arms, and more imaging studies are taken to see how the blood flows in the lungs. So it's a ventilation to examine airflow, and perfusion to examine the blood flow. Um, Impaired VQ ratio means that there is decreased perfusion and blood flow to the alveoli. A VQ ratio, which is the ventilation, air reaching the alveoli, and perfusion, blood reaching the alveoli via the capillaries. High ventilation and low perfusion. Other studies involve ABG, arterial blood gas. So low oxygen, we'll expect low oxygen due to inadequate oxygenation from the occluded vessels. There could be an X-ray for the patient, and that may reveal atelectasis or lung collapse and pleural effusion. There can be some EKG changes. BNP is tested also, and we remember that BNP is released when the ventricles are overstretched. It is increased, the BNP is increased in pulmonary embolism, but it's not diagnostic of pulmonary embolism. It's just increase in pulmonary embolism due to the stretching of ventricles. So, drug therapy for pulmonary embolism involves the low molecular weight heparin such as Lovenox, Arixtra, and Fragmin. It's given subcutaneous, it's a daily dosing, and the benefit of it is it has a longer duration of action. So let's talk a little bit first about anticoagulation. So anticoagulation is the process that prevents blood clots from forming. Now that's differentiated from thrombolytics, because thrombolytics is the process of breaking down clots after they have formed. Warfarin is an anticoagulant, and like I said before, we need to monitor the PT-INR, and we need to monitor the INR specifically. On a patient taking warfarin or Coumadin, the therapeutic anticoagulation goal should be 2 to 3 seconds. So if the INR is too high, it means the blood is too thin and the blood is taking a long time to clot. So there is an increased risk for bleeding. If the INR is too low, it means blood is so thick and there is a risk for clot formation. It will take days to reach the therapeutic level of 2 to 3 on a patient being given warfarin. So for the meantime, the patient may be given heparin. Another anticoagulant drugs is Eliquis, Pradaxa, and Edoxaban. Anticoagulant therapy is contraindicated in patients with liver problems or patients with blood dyscrasias. Intravenous heparin is also given for pulmonary embolism. When patient is taking IV heparin, we need to monitor the activated partial thromboplastin time, or the APTT. So APTT is considered a more sensitive version of just the PT, or the prothrombin time. APTT measures the length of time in seconds that takes for clotting to occur. So APTT tests the body's ability to form clot. In a normal person not taking heparin, our aim is for the normal value of 30 to 40 seconds. However, if the patient is on heparin, APTT acceptable levels is 40 to 70 seconds. So if the APTT is below the therapeutic level, so it means it's lesser than 40, we should increase the heparin infusion. This means that the blood is clotting too quickly, so heparin is adjusted. We mentioned this before, protamine sulfate is the reversal agent for heparin. So thrombolytics is another category of medications for pulmonary embolism. So thrombolytics, an example is alteplase, the TPA, and streptokinase. So the mode of action is that it reduces clot, it degrades clot, it breaks down clots. A side effect or a risk for taking thrombolytics is the risk for bleeding. Because of this, it's contraindicated in patients who have, of course, bleeding. Is an absolute contraindication for those patients who have a stroke because of hemorrhagic stroke, recent surgery, or internal bleeding. Relative contraindication would be a history of bleeding tendency, hypertension, past surgery, or thrombocytopenia. There is a surgical management for pulmonary embolism. For massive pulmonary embolism, they would recommend surgical management such as embolectomy, which is removal of the emboli. They remove the emboli by two ways, using the catheter, using an intrapulmonary artery catheter, or by surgery, which requires a cardiopulmonary bypass. We mentioned this earlier. Inferior vena cava filter, such example is the Greenfield filter, can also be used. It allows blood to pass but traps the emboli from the lower extremity. And the filter is inserted into the femoral artery to prevent migration of clot coming from the lower extremities. Nursing interventions for pulmonary embolism consist of preventive measures such as allowing the patient to use SCDs, compression stockings, early ambulation, or anticoagulant therapy. If the patient has been diagnosed with pulmonary embolism, start therapy immediately. We should assess vital signs. We should assess cardiac rhythm, oxygen levels, lung sounds. If the patient is on bed rest, we have to put them on a semi-Fowler's position for better breathing. Apply oxygen as ordered. Assess for pain and administer medications as ordered. Monitor ABG. At the onset, we will notice in ABGs the patient will have tachypnea. So they will be at risk for respiratory alkalosis. But as the disease progresses, pulmonary embolism, the patient may have metabolic acidosis. We should always make sure that the patient has IV access for medications. We monitor the PT-INR if the patient is on warfarin, and APTT if the patient is on heparin. We should monitor the platelets because patients on heparin may have risk for heparin-induced thrombocytopenia. We observe for complications of anticoagulants such as bleeding, hematoma, bruising, petechiae. We observe we institute bleeding precautions such as avoiding sharp objects such as razors, scissors, or nail clippers. They may use electric razor. We tell our patients to blow their nose gently to avoid forceful blowing of the nose. Not to use tampons, do not take rectal temperatures, and do not strain for bowel movement. To continue with nursing interventions for pulmonary embolism, we need to educate the patients on the disease process. We need to provide reassurance or emotional support. We have to remember that this patient may have some breathing problems, so they are anxious. They have this feeling of impending doom. They will be in pain. They're fearful because they have a hard time breathing. We should explain medications to patients, such as the side effects and how long do they need to take these medications. We need to explain to them the need to test for INR. We need to explain to them that they should limit foods that are high in vitamin K, such as those green leafy vegetables, because it may interfere with the efficacy of anticoagulants and thrombolytics. Avoid dehydration, smoking cessation, and preventing pulmonary embolism while traveling, such as making sure that they walk once in a while, they make sure that they exercise, they make sure that they get up and move. So this ends the lecture on pulmonary embolism and peripheral vascular disease.